We have two lectures for today, which are all reviews. I'm sure these are just reviews for you. Okay, are you able to see the screen? Is it clear?
Yes po, Doc.
Okay. Sige, so we can start. So our first topic for today is maternal anatomy, external and internal generative organs. So since our course or our subject is physiologic obstetrics, it is but fitting to start the course with the basic, and that is maternal anatomy. So this is just going to be a review of your anatomy subject in your first year. And as obstetricians or physicians attending to labor and childbirth. And also, we also do gynecologic surgeries, no, operating on them. Knowledge of the layered structure of the abdominal wall, as well as the different organs, is very important. So at the end of the lecture, we should be able to identify the different layers of the anterior abdominal wall, as well as its components, blood supply, nerve innervation, and clinical significance, followed by the specific components of the external generative organs and the internal generative organs. That is from the lower genital tract to the upper genital tract. And lastly, we'll be tackling the lower urinary tract structures such as the bladder and the ureter, as these organs are adjacent to the pelvic organs. Okay, so the abdomen is the region of the trunk that lies between the diaphragm above the inlet of the pelvis below. And as the abdominal wall is entered, several layers have to be traversed to reach the peritoneal cavity. And so we know that during pregnancy, the anterior abdominal wall has to stretch to accommodate the expanding uterus. So let's start first with the skin. So the skin is, we know that the skin is loosely attached to the underlying structures, except at the umbilicus. In the abdomen, the longer lines, which describe the orientation of the dermal fibers, are arranged transversely. The natural lines of cleavage in the skin are constant and run downward and forward, almost horizontal around the trunk. If possible, all surgical incisions should be made in the lines of cleavage, where the bundles of collagen fibers in the dermis run in parallel rows to have the best cosmetic results. So in obstetrics, we can do vertical skin incisions, such as this one, and they tend to produce wider scars compared with low transverse incision, or what we call the fan and steel, or commonly known as the bikini cut or bikini incision. This follow the longer lines, and hence they have superior cosmetic results. Okay, so the subcutaneous layer underneath the skin can be subdivided into two. The superficial, predominantly fatty layer, which is called the Camper's fascia, and a deeper membranous layer called the scarpas. These two layers are not discrete or well-defined layers. The Camper's fascia may be extremely thick, which could be about 3 inches or 8 cms or more in obese patients. The Camper's fascia continues onto the perineum, and this provides fatty substance to the mons pubis and labia majora. While the scarpa's fascia continues inferiorly onto the perineum as the colles fascia. And now, beneath the subcutaneous layer, the anterior abdominal wall muscles consist of the midline rectus abdominis, the pyramidus muscles, as well as external, internal, and transversus abdominis muscles. The fibroaponeurosis of these three muscles form the primary fascia of the anterior abdominal wall. They fuse into the midline, and which is what we call the linea alba. A wide separation of the linea alba is caused by diastasis recti or the ventral hernia. So you would expect a bulge at the anterior abdominal wall around in this area. So the composition of the rectus sheath is different depending on the arcuate line or the linea semicircularis. Above the arcuate line, the anterior and posterior layer of the rectus sheath split. Whereas if it is below, the transversalis fascia fuses with the peritoneum. So what is its clinical significance? Hematoma can occur in this area because the inferior epigastric artery, which passes through it, and these vessels may be stretched during a severe bout of coughing or in the latter months of pregnancy. The transversalis fascia is is a thin fibrous tissue layer between the inner surface of the transversus abdominis muscle and the preperitoneal fat. The peritoneum contains a single layer epithelial cells and a supporting connective tissue. And it is divided into the visceral and the parietal peritoneum. Okay, so now let's go to the blood supply. The anterior abdominal wall's blood supply is served by two vessels. The superficial epigastric, superficial circumflex iliac, and the superficial external pudendal arteries arise from the femoral artery, and they supply the skin, subcutaneous layer, and the mons pubis. The superficial epigastric artery may be affected in a low transverse incision, represented by the blue incision, the blue line here, because they course diagonally towards the umbilicus. And this should be identified halfway between the skin and the anterior rectus sheath. The muscles and fascia, on the other hand, are supplied by the vessels arising from the external iliac artery, namely the inferior deep epigastric and deep circumflex vessels. The inferior deep epigastric, on the other hand, may be transected in a Maillard's incision, and it courses lateral to, then posterior to the rectus abdominis, then above the arcuate line. So these vessels course ventral to the posterior rectus sheath and lie between this sheath and the superior surface of the rectus muscles. And near the umbilicus, the inferior epigastric anastomose with the superficial epigastric artery and vein. On each side of the lower anterior abdominal wall is the Hasselbalch triangle, represented by the green triangle here. And this is bounded by the inguinal ligament, the lateral border of the rectus muscles, and the inferior epigastric vessels. So knowledge of the Hasselbalch triangle is also important, since we know that direct hernias protrude through the abdominal wall in the Hasselbalch triangle, whereas indirect hernias do so through the deep inguinal ring lying lateral to the triangle. The anterior abdominal wall is innervated by the abdominal extensions of the intercostal nerves, the subcostal nerve, and the iliohypogastric and ilioinguinal nerves. The T10 dermatome approximates the level of the umbilicus. And so analgesia to this level is suitable for labor and vaginal birth. So clinical significance is during phalansteal incision, these nerves may be severed as it reaches the skin. Okay, as well as during a low transverse incision, ilioinguinal and iliohypogastric nerves can also be transected. So the ilioinguinal and iliohypogastric nerves can be entrapped during a closure of a low transverse incision, especially if the incisions extend beyond the lateral borders of the rectus muscles. These nerves carry sensory information only, and an injury leads to loss of sensation within the areas supplied. Okay, so let's now proceed with specific external generative organs, starting first with the perineum. So the perineum is what we call the diamond area between the thighs. And these are bounded by the um, um, areas here and the bones here. And the blood supply it is supplied by the internal pudendal artery. The pudenda or vulva, these are these include all structures visible externally from the pubis to the perineal body. So from the pubis to the perineal body, so all structures here are called the vulva or the pudenda. So the mons pubis is the fat-filled cushion that lies above the symphysis pubis. And this is covered by the hair that forms the escutcheon. Beneath the mons pubis is the labia majora. This mass of fat provides bulk to the labia majora and is supplied with a rich venous plexus. And so during pregnancy, this vasculature commonly develops varicosities, especially in parous women, from increased venous pressure created by the advancing uterine weight. They can present as engorged or tortuous veins or as small grape-like clusters, but are typically asymptomatic. So these are called vulvar varicosities. So the mons pubis is here and the labia majora is here. So onto the inner to the labia majora is the labia minora, which lies medial to each side of the labia majora. This is extremely sensitive because of the many nerve endings. However, it lacks hair follicles, eccrine, and sebaceous glands. At the inferior portion is what we call the fourchette or fourchette. So the lining epithelium, the outer and lateral portion of the inner surface is lined by the stratified squamous epithelium, while the medial portion is lined by non-keratinized squamous epithelium. So as I've mentioned, it lacks hair follicles, eccrine glands, and apocrine glands. However, it contains sebaceous follicles and few sweat glands. Okay, so the clitoris is what we call the principal female erogenous organs. The body of the clitoris consists of two corpora cavernosa covered by the ischiocavernous muscles. The glans of the clitoris is a mass of erectile tissue that caps the body of the clitoris, and it is partly hidden by the prepuce. So its clinical significance is sexual excitement produces engorgement of the erectile tissue within the clitoris. The region of the vaginal orifice, the labia minora, and clitoris are extremely sensitive to touch and are supplied by the ilioinguinal nerves and the dorsal nerves of the clitoris. The vestibule is a smooth triangular area bounded laterally by the labia minora, with the clitoris at its apex and the fourchette at its base. Within the vestibule are 6 openings, including the urethra, the vagina, and ducts of the Bartholin's glands on the two sides, and ducts of the paraurethral and the Skene's glands. which are lateral to the urethra. So the Bartholin's glands are also called the greater vestibular glands. The duct is 0.5 to 1 centimeter in diameter, and these lie inferior to the vestibular bulbs and deep to the inferior ends of the bulbocavernosus muscles. They open distal to the hymenal ring at 5 and 7 o'clock position. So what is the significance of these Bartholin's gland? Following trauma or infection, either duct may swell and obstruct to form a cyst, or if infected, it becomes an abscess. So remember where the duct opens. So ang clue natin, our clue here is the 5 and the 7 o'clock position. If asymptomatic, the Bartholin's gland cyst can be left untreated or we can just observe. But if infected, such as formation of abscess, we can do surgery. So surgery for Bartholin's gland abscess is what we call marsupialization. So it's similar to an incision and drainage. However, in marsupialization, we open the capsule and suture it alongside the wall. Okay, so minor vestibular glands are shallow glands, and these are lined by mucin-secreting epithelium. Paraurethral glands are open predominantly along the inferior aspect of the urethra. The Skin's glands are the largest, and they lie distally near the urethral meatus. So clinical significance of paraurethral glands, this could also be infected, similar with Bartholin's glands. And if obstructed, they can lead to urethral diverticulum formation. And so for the different vestibular glands, it is important to know their location and the openings. This may give us a clue as to the origin of the inflammation or obstruction based on the location. So if it's inferior to the urethra, these are paraurethral glands. And if, as I mentioned, if they are seen lateral 5 and 7 o'clock position, they may be the Bartholin's gland cyst or abscess. So let's now proceed with the vaginal opening. So the vaginal opening is rimmed distally by the hymen and its remnants. The hymen is a membrane of varying thickness surrounding the vaginal opening, and it is composed of elastic and collagenous connective tissue. So the hymen could be torn at several sites during coitus, and over time, this transforms into several nodules of various sizes called the hymeneal or birtiform caruncles. These are also the areas that is lacerated during a vaginal birth or vaginal delivery. A congenital disorder in which there is no hymeneal opening, which could obstruct the vagina, is referred to as imperforate hymen. So this is a rare lesion in which the vaginal orifice is obstructed, causing retention of menstrual blood. So the clinical presentation here is cyclic pelvic pain. However, there is no menstruation. So there is primary amenorrhea. The vagina is a musculomembranous tube that extends to the uterus. So it is interposed anteriorly and posteriorly between the urinary bladder and the rectum. The upper end is subdivided by the cervix into its fornices. And the lining epithelium of the vagina is a non-keratinized stratified squamous epithelium. There are no glands along the vagina, but there is abundant vascular supply. Okay, so the fornices, so these are the borders of the vagina, and this is the bladder alongside here, bladder, and the posterior membrane separating the vagina, and then this rectum at beneath. And the fornices are here along this side. So the fornices are clinically important because in obstetrics we can do internal examination, and so that is palpating of the internal organs. And through its thin walls, we can palpate if there are organs or obstruction there alongside the walls beneath the vagina. The posterior fornix, such as this area, provides a surgical access to the peritoneal cavity. So this is the procedure that we call coldocentesis, because the area here beneath the posterior cavity is the cul-de-sac. So we can puncture the posterior portion, we can puncture the cul-de-sac and can do coldocentesis, and we can retrieve blood or abdominal or abnormal fluid from the cavity. So it can provide access to the peritoneal cavity. We rarely do it anymore, but it is important, or sometimes can be done if you're entertaining ectopic pregnancy, okay, or especially ruptured ectopic pregnancy. So as what we have mentioned, the vagina is separated from the bladder and the urethra by the vesicovaginal septum. So this one, vesicovaginal septum. Here pala. Vesicovaginal septum. So uterus pala to. Vesicovaginal septum. And then posteriorly, similar tissues form together, and this is what we call the rectovaginal septum, between the lower portion of the vagina and the rectum. The upper fourth of the vagina is separated from the rectum by the rectouterine pouch or the cul-de-sac of Douglas. Here, along here. Dito pala. Okay, so let's mention the blood supply. So as we said, vagina has an abundant blood supply. The proximal part of the vagina is served by the cervical vaginal branches of the uterine and vaginal artery, whereas the posterior vaginal wall is supplied by the middle rectal artery and the distal walls by the internal pudendal arteries. At each level, the vessels supplying each side of the vagina course medially across the anterior and posterior vaginal wall and form a midline anastomosis. So these vessels are present along each side of the vagina, and they form and fuse in the midline and anastomos. So the perineal body is a fibromuscular pyramidal mass in the middle at the junction of the anterior and posterior triangle. It provides significant perineal support. So this is a picture of the, if you can imagine, this is the head of the baby. This is the perineal body alongside here. So from the, it is the portion between the posterior fourchette and down to the anus. So it's clinical correlation. So we usually do an episiotomy or incision during childbirth or vaginal birth alongside the perineal body. So this can be torn with second, third, or fourth degree lacerations. So let's now proceed with the inner structures. The perineum is also subdivided into superficial and deep spaces by the perineal membrane. The anterior triangle is also called the urogenital triangle, whereas the posterior triangle is called the anal angle. And these are divided by the ischial tuberosities along each side, and they form the base here. So the anterior triangle further subdivides into a superficial space and a deep space. So the superficial space is a closed compartment, whereas the deep space is continuous to the pelvic cavity. The different components of the superficial space of the anterior triangle is composed of the Bartholin's gland, the vestibular bulbs, the clitoral body and crura, and the branches of the pudendal nerve and vessels, and the ischiocavernosus, bulbus sponjosus, and superficial transverse muscles. The deep space of the anterior triangle lies deep to the perineal membrane and extends up, as I mentioned, continues superiorly with the pelvic cavity. So it contains portions of the urethra and vagina, portions of the internal pudendal artery, and muscles of the striated urogenital sphincter complex. Deep to the anterior and posterior triangle is a muscular sling which provides support to the pelvic viscera, and so we call this one the pelvic diaphragm. The pelvic diaphragm is composed of the levator ani muscles and the coccygeus muscles. So the levator ani muscles is composed of the pubococcygeus, puborectalis, and iliococcygeus. So the posterior triangle is a triangle which contains the ischioanal fossa, the anal canal, and the anal sphincter complex, and also the branches of the pudendal nerve and internal pudendal vessels. The ischiorectal or ischioanal fossa are fat-filled wedge-shaped spaces on either side of the anal canal. These provide support to the surrounding organs, yet they allow rectal distension during defecation and vaginal stretching during delivery. Injury to the vessels in the posterior triangle can lead to hematoma formation. And this is also potential for large accumulation of hematoma. The anal canal is a distal discontinuation of the rectum, which begins at the level of the levator ani, attachment to the rectum, and ends at the anal skin. It has several tissue layers. The inner layer include the anal mucosa, the internal anal sphincter, and the intersphincteric space. The outer layer contains the puborectalis muscles and the cephalad portion, and the external anal sphincter caudally. The internal anal sphincter contributes the bulk of the anal canal resting pressure for fecal continence. And this is formed by the distal continuation of the inner circular muscle layer of the rectum and colon. So it is also important to know the internal anal sphincter and the external anal sphincter, as these may be lacerated in during vaginal birth or childbirth. Within the anal canal are three highly vascularized submucosal arteriovenous plexuses termed the anal cushions. They aid in complete closure of the canal and fecal continence. The increase in uterine size, the excessive straining, and hard stools create increased pressure that ultimately leads to degeneration and subsequent laxity of the cushion's supportive connective tissue base. These cushions then protrude into and downward to the anal canal, which leads to venous engorgement within the cushions, and these are what we call the hemorrhoids. Venous stasis resulting in inflammation, erosion of the cushion's cuboidal epithelium, and then it may cause bleeding. The pudendal nerve is formed by the anterior rami of the S2 to S4. They course between the piriformis and coccygeus muscles and exits through the greater sciatic foramen at a location posterior to the sacrospinous ligament, just medial to the ischial spine. It is okay. There are three terminal branches of the pudendal nerve, namely the dorsal nerve of the clitoris, which supplies the skin of the clitoris, the perineal nerve, which supplies the muscles of the anterior triangle and label skin, and the inferior rectal nerve, which supplies the external anal sphincter, the mucous membranes of the anal canal, and the perineal skin. So why is pudendal nerve important also? So this is where we can do our pudendal block. So we can infiltrate local anesthetic to the pudendal nerve, and it will block that area. So a very important landmark to locate the pudendal nerve is the ischial spine. So the pudendal nerve is relatively fixed as it courses beneath the sacrospinous ligament within the pudendal canal. It may also be at risk for stretch injury during childbirth during downward displacement of the pelvic floor. So for us to be able to infiltrate the pudendal nerve, we need a long needle, such as a spinal needle. So we can palpate first the ischial spine, and that is to locate the sacrospinous ligament. Any questions so far with the external genitive organs? Okay, so can proceed with the internal genitive organs. So let's start first with the cervix, which is a cylindrical portion of the uterus. So it is divided into the internal cervical os and the external cervical os, and along is the endocervical canal. After childbirth, the external cervical os becomes a fish mouth appearance after childbirth. Before childbirth, it is small. It has a small and oval opening. Its stroma is composed mainly of collagen, elastin, and proteoglycan, and very little smooth muscles. The ectocervix is lined by non-keratinized squamous epithelium, and the endocervix is lined by mucin-secreting columnar epithelium. So very important din there's what we call the transformation zone, where we do our pap smears. Okay. So correlation of the cervix after labor. The orifice is converted into a transverse lip that is divided into anterior and posterior lip. It can also present as cervical eversion as the cervical epithelium moves out onto the ectocervix. Okay, so when the woman becomes pregnant, there is increased vascularity within the cervical stroma, and it will appear as purplish or bluish discoloration. And this is what we call the Chadwick sign. So after the cervix, we go to the uterus, which is a thick-walled, hollow muscular organ. The non-pregnant uterus lies in the pelvic cavity between the bladder anteriorly and the rectum posteriorly. So it is nice to know the dimensions in a nulliparous uterus and a multiparous uterus. And very importantly, it is supplied by the uterine artery and the ovarian artery. So the walls of the uterus is covered by the visceral peritoneum, or what we call the serosa, whereas the anterior wall is covered by the serosa on the upper portion. Along the caudal portion, anterior peritoneum reflects forward into the bladder dome to create the vesicouterine pouch. So this vesicouterine pouch should be identified, and this is where we do our incision during a cesarean section. The vesicouterine space separates the lower portion of the anterior uterine wall from the posterior wall of the bladder. So the different parts of the uterus, so it is composed of the corpus or the body, the cervix at the lower portion, the cornua at the junction of the superior and lateral margins, and the fundus, which is the convex upper segment between the points of insertion of the fallopian tube. It is also a pear-shaped organ, and the upper larger portion is the body or the corpus, and the lower smaller cervix projects into the vagina. And we call it the isthmus, which is the union of the lower portion of the cervix and the lower portion of the uterus. And this isthmus or lower uterine segment is very important during pregnancy. So the layers, the serosa, which is the outer portion, the muscularis layer or the muscle layer, the myometrium, and the inner layer, we call it the endometrium. The myometrium is composed, the bulk of the uterine cavity, except the cervix, is muscle. And bundles of smooth muscles are united by connective tissue with elastic fibers. There is relative more muscle in the inner wall than the outer wall, and in the anterior and posterior walls than in the lateral walls. So very important, the interlacing myometrial fibers that surrounds the myometrial vessels are integral to control of bleeding from the placental side during the third stage of labor. So the formation of the interlacing fibers are very important in the control or in the prevention of hemorrhage after a delivery. So they are formed by interlacing myometrial fibers. The inner wall or the endometrium is composed of overlying epithelium, invaginating glands, and very vascular stroma. It is the mucosal layer which lines the uterine cavity in a non-pregnant woman. And the thickness of the endometrium varies depending on the cycle of the menstrual cycle. It is composed of the surface epithelium, invaginating glands, and interglandular mesenchymal stroma. The vascular architecture of the uterus and the endometrium is of significant importance in pregnancy. The uterine and ovarian arteries branch and penetrate the uterine wall obliquely inward and reach its middle third and then ramify to form or to become the arcuate arteries. And then the radial arteries go up and form the spiral or coiled arteries, and then the basal straight arteries. So what are the supporting structures of the uterus? So there are several ligaments which extend from the lateral surface of the uterus towards the pelvic side walls. So these include the round ligament, the broad, and the cardinal ligaments. The round and the broad ligaments actually they do not provide substantial uterine support, in contrast with the cardinal and uterosacral ligaments. The round ligament arise below and anterior to the origin of the oviducts. So it is one of the this is one that has to be identified during a uterine surgery. So we call it the R, the round ligament, T, the tube, and the ovary. So that is its placement. R, round ligament, the tube, and the ovary. The broad ligament, on the other hand, these are wing-like structures from lateral margins to the pelvic walls. They divide the pelvic cavity into the anterior and posterior compartments. The peritoneum that overlies the fallopian tube is called the mesosalpinx. That around the round ligament is the mesoteres, and that over the uterovarian ligament is the mesovarium. The peritoneum that extends beneath the fimbriated end of the fallopian tube to the pelvic wall forms the infundibulopelvic ligament, or the suspensory ligament of the ovary, through which the ovarian vessels traverse. So during pregnancy, these vessels, especially the venous plexuses, are dramatically hypertrophied. The cardinal ligaments are what we call the transverse cervical or Mackenrod's ligament. They form a thick base of the broad ligament, and that is continuous with the connective tissue of the pelvic floor. The uterosacral ligament extends from an attachment posteriorly to the supravaginal portion of the cervix and inserts into the fascia over the sacrum. So this is alongside the posterior wall, uterosacral. They also form the lateral boundaries of the pouch of Douglas. Uterosacral ligament. Okay, so as we have mentioned, the vascular supply of the uterus is derived principally from the uterine and the ovarian arteries. The uterine artery is the main branch of the internal iliac artery. So we can trace the course of the uterine artery. It enters the broad ligament and then medially to the lateral side of the uterus. And at 2 cm lateral to the cervix, the uterine artery crosses over the ureter. At the supravaginal portion of the cervix, it also divides into the supravaginal artery, which supplies the lower cervix and upper vagina. The main uterine artery branched to penetrate the uterus to become the arcuate artery, and then the radial artery, and then onto the spinal artery and basal arteries. The ovarian artery is a direct branch of the aorta, and it enters the broad ligament through the infundibulopelvic ligament. So the dual uterine blood supply created by the uterine artery and the ovarian artery creates a vascular reserve to prevent uterine ischemia if ligation of the uterine or internal iliac artery is performed. Okay. Lymphatics and innervation. So along the cervix, the lymphatics terminate mainly in the hypogastric nodes, which are situated near the bifurcation of the common iliac vessels. Alongside the body of the uterus, the internal iliac nodes and the periaortic lymph nodes. Innervation is by the sympathetic innervation arising from fibers of the spinal level T10 through L2. The fallopian tubes are also called the oviducts, and these tubular extensions from the uterus varies in length from 8 to 14 centimeters. The isthmus, or the narrow portion of the tube that adjoins the uterus, passes gradually into the wider lateral portion, or what we call the ampulla. The infundibulum, or the fimbriated extremity, is the funnel-shaped opening of the distal end of the fallopian tube. So the fallopian tube also varies considerably in its thickness. The narrowest portion of the isthmus measures 2 to 3 centimeters in diameter, and the widest portion of the ampulla measures 5 to 8 centimeters. So clinical significance of the fallopian tubes is the ectopic pregnancy or the extrauterine location of an abnormal pregnancy. So fallopian tubes are composed of tubular smooth muscle, the inner circular and outer longitudinal, and they undergo rhythmic contraction or peristalsis towards the uterine cavity. So very important, yung contractions towards the uterine cavity. So it propels the um, the ovulated when there is ovulation, it propels from the ovaries towards the uterine cavity. Very importantly, also there is no submucosa in the fallopian tube. The epithelium is in close contact with the muscle layer because of there is no submucosa. Okay, ovaries, they vary considerably in size. So during childbearing years, they can be from 2.5 to 5 centimeters in diameter, whereas during the menopausal years, these ovarian size diminish remarkably. They rest in the slight depression on the lateral wall of the pelvis called the ovarian fossa of Waldeyer between the divergent external and internal iliac vessels. They are attached to the broad ligament by the mesovarium and also attached to the uterus by the utero-ovarian ligament. So parts of the ovaries, the cortex or the outer layer contains the oocytes and developing follicles, whereas the central portion or the medulla is composed of loose connective tissue. Blood supply, the ovaries are supplied with both sympathetic nerve from the ovarian plexus and the parasympathetic nerves. Okay, let's proceed with the adjacent organs to the internal genital organs such as the bladder and the ureter. So we know that the bladder rests anteriorly against the inner surface of the pubic bone. Posteriorly, it rests against the vagina and cervix. The dome is composed of the bladder is composed of the dome and a base. And the bladder wall consists of smooth muscle called the detrusor muscle. Blood supply of the bladder is from the superior vesical arteries, middle and inferior vesical arteries. Blood supply of the ureter is common iliac, internal iliac, uterine vessels, and the superior vesical vessel. So it is also important to know the course of the ureter. So as the ureter enters the pelvis, it crosses over the bifurcation of the common iliac. And then it descends into the pelvis and lies medial to the internal iliac and anterolateral to the uterosacral ligaments. It traversed through the cardinal ligament approximately 1 to 2 cm lateral to the cervix. And so along this area where the uterine artery crosses over the ureter, this is the area where there is commonly transection or the ureter can be avulsed during a uterine surgery such as hysterectomy. So that area is very important or significant. Since the ureter is very close to the uterine artery. At the uterine isthmus, it courses below the uterine artery, and then it traverses anteromedially towards the bladder base. So that's very important na yung course ng ureter. So this is the last slide of the first part of the lecture. Any questions with anatomy?
Nando.
Yes. None. Sorry. Okay. Can we just have 5-minute break before we proceed with the second lecture?
Okay po, Doc.
Okay.